Yes, Reetta, hello. So the idea of the laboratory tests about what we thought was about the major tests we need today in rare epilepsies. And when we discussed this for our first meeting, that was not the climax, but it was a simple meeting last year, we had, this is a joke special for later, we had a decision to look for genetic, metabolic, and autoantibodies and all the immunology, I would say, workup that we will need. And the idea is to map for this first year the existing groups that can provide these tests to see if they can provide them also for special requests from other groups, and basically to see how we can do better in guidelines, when to do these tests, and even to go into, and this is a discussion that we should do this year with more the research group, because we will need to settle, or within our group, or in addition with some genetic groups working on this, how to understand, how to do the interpretation for some difficult to analyze results. Basically that some of the centers, and you will see this very quickly, they refer to private labs or to private facilities to do these tests. So, the survey, it was aimed to map the existing. It was indeed aimed to all the points that I raised before, to know how it is done, where it is done, if it is reimbursed or not. This was a very important point because we know that some of these tests are not yet included, and some centers answers about this, within the reimbursement that is provided for these patients. We asked also 2 tiny questions about the needs and definitely about the expectations that the centers have from the EpiCARE network on this.
Can I comment on this? I think my view on this is that it's very important to have the access to the tests and not to do them yourself. So it's very, very important that we now survey how people can access the tests, and especially perhaps in the future we also need to include more data about how bioinformatics is available in the clinics, because it's not so important that we emphasize the actual that you actually do yourself.
No, definitely, definitely.
So that's
if you have an access, but it's important to see.
Access and also the compensation.
Exactly. So this is the please respond of Judith. I don't know where is Judith now. We had 20 surveys that were sent in May 2017. 20 answers were received before July, and 6 responses. We had to do some reminders, but this is just to emphasize, and we didn't have the 28 surveys answered, that we should really be careful about our thinking in projects or surveys, and even a survey that is tiny like this, people didn't find time to answer or to retrieve the data we needed, although these were very simple data. So I will not do a list of all of this, but just to emphasize that many of the centers, if you do 16, 2, and 4, you have many of these centers will have access for these tests, as you were saying, in-house or in other institutions. It is the same for advanced metabolic. So it's for the basic metabolic, the advanced metabolic testing, which is really important to know. It is more or less the same for the genetic testing. And there is, if you look at this, I cannot see the pointer. At this point, there are some centers that are able to provide these testing for other European countries, or for centers that do not have this expertise. This is about the single gene testing. Again, it is everywhere, I would say, and there is a possibility to do it for other EU citizens. When we arrive to exome sequencing, we are getting in less centers that are able to do this, and the whole question is, the guidelines today are with panels. If we will arrive to exome sequencing at some moment, definitely centers will not be able to follow. This is another discussion, but this is important. And we can see immediately here that the number of centers that can offer this for other countries is becoming really very, very less important, I would say. And if we look for this, for instance, for exome sequencing, many of the centers are doing this based on research funds, which was a bit expected. I will just get into this slide, which is about the reimbursement policy. What is blue, what is fully reimbursed, what is green is what is not reimbursed. And when you look at, for instance, in some countries, in one country, I'm sorry, in some countries, panels are not reimbursed. Exomes in more than 4 or 5 countries are not at all reimbursed. But what is interesting that in 3 countries, even antibodies are not included within what you can do for a patient with, when you have a suspicion of diagnosis of autoimmune antibodies. So there are not a wide, I would say, heterogeneity for our health system, but there are mainly 2 countries that they ask for the EpiCARE, I would say, guidelines and to help them for their health authority to get these tests reimbursed. So this is basically, these are basically the conclusions. So there is not a huge heterogeneity, and we have these tests. There is a possibility to offer these tests for EU patients, and the discussion should be, and this will be one of our further discussion, how to select these patients. It doesn't mean that we can offer it, that we can receive a DNA tube and we can do it. And then, as I said, the help for the reimbursement policies. And definitely, and here we should discuss this with the research group, basically for genetic work, how to can couple the efforts on this genotyping with the data collection, with international initiatives, and we will have a discussion with Renzo and the group of research about this. So, this is what I wanted to tell you about the survey, and what are our future actions. So the future actions are indeed on 4 axes, I would say. Number 1, we need to work with the guidelines group about when to do, because many of the centers commented that they need some guidelines to be able to to ask for reimbursement of these tests. So we need to work on provide some criteria for these testing. The other point, do we have to support for the difficult case discussion something for laboratory testing? I was talking about the analysis of the genetic results of the difficult, I would say, how to validate this, that this mutation or that this abnormal sequencing is causal or not. These are very important discussions. I don't know if we should go into this, but definitely we are not ready at all to discuss this today. The 3 other points are more accessible, I would say. We all know about the orphanet thesaurus. It will be more and more, I don't know, in your countries, I would like your feedback, requested to classify the rare diseases. We will have to, for epidemiological studies, to act our activities, and the idea is to get back to this orphanet thesaurus within the group and to work on it, because for those who knows what is this thesaurus, it's just a nightmare. And what we discussed with Orphanet is to do during the coming 4 years, updating for 6 to 8 syndromes per year, the 1 page that we see in Orphanet, and orphanate accepted, and they are more than happy to do this. We will work with the metabolic diseases, ERNs, on guidelines for metabolic epilepsies. And for this, I'm looking for the neonatal group. The neonatal group should be involved for all the vitamin-sensitive neonatal epilepsies, and they are really keen because, as Helen was saying, they are much more centers and they have more people to work on that, so they will accept, they are happy to work on this with us. And the final point that we were discussing yesterday as a steering committee, and this can find some funds via the European Joint Programme on Rare Diseases, if we think about doing a symposium, a kind of, within the frame of the teaching symposia on genetics of rare epilepsies. And I was thinking that we can do it with the ERN on developmental genetic diseases and with the metabolic ERN. And for this, we can open it for some trainees, for some, MDs who are preparing and who are involved in rare diseases, and we can have funds for this. So this is almost all what I wanted to say on this, and I just wanted to have some thoughts with you on this. So Helen has the 5 options. She will tell about this in this afternoon. No, what I mean that definitely we do not have funds to do all of this. We are discussing, every group is discussing about surveys, about projects, and this should be something that we should really discuss and restrict for things that we will be able to do our activities and to set our goals on things that we will be able to achieve. Reetta, if you want to add something. Questions?
Yes, exactly.
Or comments or proposals.
That's right. Has anybody got any specific questions?
Alison Watson, I'm from March18. I'm particularly interested in the fact that your survey covered a number of different types of genetic testing and asking centres what they offer. And as we know, for ring chromosomes specifically, none of those testings that you requested about CGH, exome, whole genome sequencing, etc., will pick up yet a ring chromosome. And we have a number of ring chromosomes associated with epilepsy. So what's the thinking, are this group thinking about how they might tackle ring chromosomes, and is that on your agenda?
I think what we discussed yesterday was to put ring chromosome 20 on our priority list for orphanate, and to emphasize how we do the cytogenetic testing or over 100 meters and all the things, and to emphasize this because this can be one way to widespread this information for chromosome 20. And definitely...
And ring chromosomes,
exactly. And because we have other ring chromosomes pathologies, exactly, that we should... Exactly. So this is one of the things that we were thinking about specifically for this, and to be able, because orphanate is something that is accessible, and we can put these informations also on our site. So it will be a double, I would say, entrance for this. Then we can definitely also ask for centers that are doing this, but it's more because, the cytogenetic labs existed much before the genetic new, I would say, the NGS labs. But what is important for this is to ask how to do the test. So I think what we should emphasize is, when do you think about it and how to do the test? Because definitely many hospitals will have this facility.
I totally agree with you. I think the importance is about the clinicians recognising the possibility of a required zone and then understanding the correct testing to apply. So I think we've got to tackle it from both sides.
Happy to that we agree on that.
So just an anecdotic case. In our clinic, we don't actually think very often to linked chromosome 20 or other linked chromosome syndromes. So therefore, in this time, we refer for panel genes. But our colleagues from genetics happily think about this and do the regular karyotype if nothing comes out from...
Not the regular one.
They have to ask for they look for
and they look for the ring chromosomes.
Yeah,
we
and it was
completely agree.
things like that when they discovered. We didn't order, but they did more than we asked. So maybe it will be nice to put this in our workup.
Definitely. Eugen and then
Eugen
and then.
So thank you very much. This is, I think, a very important thing with what you did here, and the thing you mentioned already is the link for reimbursement and having guidelines. So and that came up from several centers that they need guidelines or clinical recommendations when to do which test. I mean, you absolutely know much better than I. The difficulty is there is no evidence that you have to do this, and you know the diagnostic sensitivity specificity. So I think that having attacked this problem, what to really recommend for everyone and which strategy to recommend is a major issue. And it's not only the linkage to the metabolic group, it's also the linkage to other groups, which also need that outside certain age groups. So we start to test also in adults, even at the later stage, and there's absolutely no knowledge about the sensitivity when you find something there, when something happens at the older age. So I think this will be a major task, and to see how fast the field moves forward, I think it should be every year
updated. So it might be even that we should start, although it's difficult, to put some kind of, as you said, clinical recommendation for certain situations, what to do with certain cases. And although it's difficult, and although we are a little bit hesitant to do it, but as there are these clear situations where we need to do molecular karyotypic diagnostics before going to exome sequencing. But that's not happening, and even perhaps in our centers, a little bit harmonizing these situations would be very good. And updating it. Now we are a little bit hesitant to put any recommendations.
I think that hesitation is often that, everybody says guidelines, often wants evidence. But recommendations, and especially if you harmonise it across different ERNs, I think would be perfectly reasonable. Sorry, Carol was first, yes.
A very basic question. Thank you very much. As a result of the survey, available somewhere special data on centers which can offer something for the others?
That's something we need to
This is why I said we should discuss about the modalities. Because if, I don't know, Renzo is here, if he's saying we can offer this, I don't believe, but he can answer for himself, that he can receive tomorrow 400 DNA without phenotyping. Just do for us the panel of genes. I believe that. This is why I think this should be one of our first discussion for the coming months, to see how we can offer this and in which conditions. And in which frame, I would say. It's not about conditions.
Something would be good would be to have recommendations,
Exactly.
and then sort of some knowledge in your country or whatever about where you can send it. I mean, those would be two key bits of information. Last question, because we have to move on, but then
I think it's crucial if you think about recommendations and possible laboratory options that you will prioritize towards treatment disorders. So you should make first a list of the few treatable, metabolic, and even targeted therapies for genetic disorders that we have to prioritize in diagnostics.
And this was something that we also discussed in the targeted.
that will come up later, so that's going to come up later.
And this is why I have to admit that we initiated with the metabolic work up, but I completely agree that there are some other targeted diseases, not metabolic.
And the last thing I wanted to say is that if we're going to think of 5 diseases that we, or a number of diseases that we update with Orphanet, having volunteers to
Yes.
help with that would be really useful.
Yes.
So if anybody feels a burning desire that they want to help with the information on, have you made the list of diseases that we're going to prioritise?
We will
Email it. Okay, fine.
And when we will have more than 10 persons asking to do the same job, we will advertise and we
Okay.
will see.
All right.
So,
Thank you. Okay, we'll move on. Thank you very much.